Chapter 18 in the Jarvis covers assessment of the thorax and the lungs. In order to get the most from your reading and studying, remember that the purpose of the physical exam is to detect both normal and abnormal findings and to document them appropriately. You should always start with your general survey and then proceed in an orderly fashion. Obtain the appropriate subjective data first and then your objective data. Analyze and interpret your findings, and then prioritize and create a plan of care. Report the pertinent information, and then delegate as appropriate, and provide feedback and education to the patient, the family, or the caregivers. The focus of this chapter is to assess the respiratory system. Always observe the rate, depth, and effort of breathing. Look at the positioning of the patient. Are they using any accessory muscles to breathe? In pediatrics, nasal flaring, grunting, and assuming the sniffing position are all signs of increased work of breathing. Head bobbing is a sign of distress and impending respiratory failure or arrest. Look at the skin color. Pallor indicates hypoperfusion or shock, and cyanosis indicates poor gas exchange and hypoxemia. Oscillate and interpret the importance of adventitious lung sounds. Review the chest anatomy, paying particular attention to the internal and external structures and the landmarks. One of the things I really want you to appreciate is how to accurately oscillate the chest, avoiding any underlying structures that will inhibit accurate transmission of sounds, and where to place your stethoscope so that you can actually oscillate all of the lung fields accurately. Review and understand the mechanics of breathing. Ventilation is the process of air movement, while respiration is the actual gas exchange. Inspiration is an active process that requires energy. The diaphragm contracts and flattens, pulling down and creating a vacuum. At the same time, the intercostal muscles contract and lift and expand the rib cage, kind of increasing the container size, which creates an even greater vacuum, pulling air in from the environment through the mouth and the nose. Exhalation is a passive process where all of these muscles, the diaphragm and intercostal muscles, relax, and then there's increased interthoracic pressure, which just allows the air to escape. The diaphragm moves up and down in the middle, but is anchored at the edges, so it's actually attached kind of around the wall of the thorax. And in the middle of the diaphragm is the cardiac sphincter, where the esophagus goes through. In the diseased patient, exhalation becomes an active process and requires significant energy to exhale. So patients who have end-stage lung disease, such as COPD and emphysema, require additional energy to exhale, and that's why at the end they become very cachectic. They don't have enough energy to both breathe and eat, and so they spend all of their energy breathing, obviously, and lose weight and can't eat. So for our assessment, we're going to collect subjective data first. Any complaints should be evaluated with onset, provocation, quality, region and radiation, severity, timing, and what do you think is going on. Inspect the thorax anteriorly and posteriorly, looking at the thoracic cage, assessing respirations, skin color and condition. The person's facial expression will give you a lot of cues as to how much distress they're in and their mental status. Palpate the anterior and posterior chest, confirming symmetric expansion and tactile fremitus. Detect any lumps, masses, or tenderness. There's really only light palpation of the chest wall since the rib cage does not allow for deep palpation. Percussion occurs in between the bones, so in between the ribs you're going to percuss, and you can percuss the lung fields and estimate diaphragmatic excursion. While you're percussing the posterior thorax, most providers also percuss the costovertebral angles at the back to see if it elicits any pain over the kidneys. And then you can auscultate breath sounds, noting any abnormal or adventitious breath sounds, and perform bronchophony, whispered pectoraliquy, and egophony as needed if there are any abnormal auscultated sounds. Inspection of the chest starts with removing the patient's shirt or gown and just visualizing the shape and configuration of the chest wall, noting the position the person takes to breathe, and assessing skin color and condition, and this includes nail beds and looking for clubbing. Assess the quality of respirations. Are they rapid, shallow, deep, labored, and any abnormal patterning. Abnormal findings for respiratory patterns are covered in your book on page 444, and those would include tachypnea, which is a rate greater than 20, bradypnea, which would be a rate less than 12, hyperventilation, which is a sustained rapid deep respiratory pattern. We see this as a compensatory mechanism in things like Kussmaul's respirations in the DKA patient, where you're trying to blow off CO2 to maintain an acid-base balance. And then we see this as a physiologic side effect of things like panic disorders, where the person then blows off too much CO2 and has a syncopal episode, and it's self-correcting. Hypoventilation then comes from central nervous system disorders, drug overdoses, CNS depression, and that is a slow and shallow respiration. If you see the word hypoventilation, slow and shallow respiration, if you detect that your patient does not have an adequate minute volume so that the rate and depth combined do not equal adequate gas exchange, then the immediate life-saving intervention is going to be to provide positive pressure ventilations. It's not enough to give oxygen to a hypoventilating patient. They need volume. Cheyne, Stokes, and Biot's respirations, as well as things like ataxic breathing and agonal breathing, are patterned respiratory issues that you might find depending on different lesions or problems in the brain. Cheyne Stokes we often see at the end of life, but it's also a normal finding in children because they only breathe when their CO2 level gets high. And then air trapping. So one of the things that we know is that patients who have chronic obstructive pulmonary disease, especially again at the end stage, require extra time for exhalation. And if they are in distress and they're trying to breathe quickly, so they have tachypnea, as you're trying to breathe rapidly to increase your oxygenation, you don't have adequate time for exhalation, and you start to have air trapping, which leads to the inability to inhale or exhale, and the person then starts to do what looks almost like guppy breathing, which is this very rapid, shallow breathing, and basically they need to be slowed down and allowed to exhale to get some of that air out so that they can take an actual another full breath. You may notice some chest wall deformities. So pectus excavatum and pectus carinatum are two chest wall deformities that you may see. These are congenital chest wall defects. The major concern with chest wall deformities are the ability for the chest to adequately expand in order for gas exchange to occur. Chest wall deformities can be very mild and they can be very severe. Sometimes they include just the manubrium, sometimes the body of the sternum, and sometimes just the xiphoid. So just document those. These you will not see frequently enough for you to necessarily remember these terms, but if you do see them, you could just easily remember I need to look this up so that I'm documenting with the correct word. Barrel chest, you'll notice with patients who have an increased anterior posterior diameter, and this again usually is a result of something like chronic obstructive pulmonary disease where the person has had to work hard to exhale. You may also see this in other lung diseases such as cystic fibrosis. Scoliosis and kyphosis both create abnormal shapes and compression of portions of the thoracic cage or the rib cage. And this becomes a concern for us because during times of illness, the person can't fully take a breath, which means that they are at increased risk for impaired gas exchange, increased risk for pneumonia, increased risk for hypoventilation and problems following like surgical procedures. So if you have a patient who has a deformity of the thoracic cage, make sure that you're doing a really careful lung assessment. And here's kyphosis. And some of these patients lose a significant amount of weight as this curvature becomes more and more prominent, and they really can't take a deep breath at all, and even placing them on oxygen won't improve their oxygenation because the diaphragm just can't expand. So as you're doing your assessment after inspection, you're going to palpate. So now just use your fingers and gently palpate the entire chest wall. It's up to you if you want to do the entire anterior and then do the posterior, or if you want to do like all of the inspection and then all of the palpation. However it works for you and for that patient for their condition at that time. Just, be flexible. So note again, any evidence of injury, illness, abnormal findings. So you're going to be looking for injury, you're going to be looking for disease, you're going to be looking for both skin masses as well as underlying bony, muscular, or organ dysfunction. And then palpate for symmetric expansion, keeping in mind of things like kyphosis and scoliosis. They may not have symmetric expansion at baseline, and it's not a lung disorder, it is a skeletal disorder. And then palpate for tactile fremitus if abnormal sounds are heard. And you can have increased tactile fremitus over areas with consolidation such as pneumonia. So if you hear something that sounds like very rhonchorous, or you hear like maybe some crackles or wheezes in just one area, and you put your hand over that while the patient's breathing, you might feel some increased vibrations in that one area, and that would be an indication that there's a pneumonia or consolidation there. You have decreased tactile fremitus over areas where there's decreased airflow, such as obstruction or pleural effusion, a pneumothorax, or emphysema. Rhonchi, so rhonchal fremitus, occurs over rhonchi in the large airways, and so you would palpate like kind of directly over the sternum. With somebody who has COPD and a lot of mucus production, you can feel rhonchi directly over the sternum. And then if you're suspecting a pleural friction rub, you can actually palpate it, so you can feel pleural friction fremitus directly over the area where you hear a rub. Percussion is not a technique that the normal long-term care, acute, subacute, or primary care nurse is going to use frequently, but depending on your scope of practice, this may be something that you use every once in a while. It, again, is non-invasive and it's not painful. So if you have a patient who has some interesting findings and you want to try this, it's certainly not going to be harmful as long as their current condition allows you to do this. So you wouldn't want to do this in someone who's critically ill, who's absolutely exhausted every time they need to take a breath. So you're going to percuss in the intercostal spaces if abnormal lung sounds are heard, to check for consolidation. And then you can also percuss diaphragmatic excursion, so you can see how well the diaphragm is moving. This might be helpful in a patient who maybe has like ascites or something like that, or you're worried about a pleural effusion. So basically, you're having the patient exhale and you're percussing to see where it moves from being resonant to dull, and that's showing you where the diaphragm is at its highest. And then you have the patient inhale, and then you again percuss to see where it moves from resonant to dull, and that tells you where the diaphragm is at its lowest, and that gives you a measurement of diaphragmatic excursion. In 27 years, I've never seen anyone do this, and I've never been asked to do it, so I can't tell you that it happens frequently, but it is a thing. So if you ever want to try it, let's do it. So just to give you an idea, remember that percussion is certainly an assessment tool, however, and you should know what to expect for normal findings. So if you are percussing, again, in between the bones, because bones have their own sound, so you want to percuss the actual lung fields, hyperresonance would occur if the patient has emphysema or a pneumothorax. So hyperresonance is increased like echoing sounds. Resonance is normal. So over your lung fields, over the lungs themselves, you should hear resonance. Once you hit the diaphragm, it should be dull. And that's true also if there's like a pleural effusion. And over like the liver, the spleen, and the kidneys, it will be dull because those are solid organs. Over the heart itself, it's dull because, again, that's an organ. And then over muscle or bone, it should be flat. So you should be able to identify those landmarks kind of underneath the skin, and then figure out where you're percussing and get in between the ribs and percuss. The next step would be oscillation. When you're oscillating, the important things to remember are that you should compare side to side. So don't just do one down one side and the other. Always move side to side, comparing the right and the left. It's important to know the normal breath sounds. So the tracheal, the bronchial, the vesicular, and the bronchial vesicular. And then to know the adventitious breath sounds, crackles, rhonchi, wheezes, pleural friction rub, and stridor. And stridor is not a breath sound, but because you do oscillate over the trachea as well, it's listed here. What I really want you to appreciate from this slide is that you can't get there from here. And what I mean from that is that if you only listen over the front, you are not going to really be able to oscillate the lower lobes on either side. And if you only listen over the back, you're not going to hear the right middle lobe at all. So this gives you a nice diagram of the minimal number of points you should listen to. So it shows you trachea, it shows you apices, it shows you kind of middle on both sides and then lower on both sides anteriorly. And then it shows you again apices, mid, and lower on the posterior. And you'll notice that each book or author has their own suggestion of how many places you should listen. Just make sure that you're listening at a minimum to top, middle, and lower, front, and back. If you hear abnormal sounds, you should check for what's called vocal fremitus. So tactile fremitus, again, is where you put your hand on the chest and you feel for vibrations. Vocal fremitus is now listening for resonance, or listening for, very much like listening for a bruit versus palpating a thrill. Tactile fremitus would then be similar to a thrill, where vocal fremitus would be listening to the bruit. So you, in bronchophony, have the person say 99, 99, 99, and normally it's really hard to hear. If there's consolidation, it's amplified and you can hear it clearly. With egophony, you ask the person to say E, and normally you can kind of hear E, but if the person has consolidation, it's amplified and you actually hear the sound A. And with whispered pectoriloquy, you ask the person to whisper 1, 2, 3. And normally you can barely hear it, but if there's consolidation, then it would be amplified. So the take-home message is that if the patient has either like pneumonia or a tumor or a pleural effusion, and you're listening over it while they're talking, the sound is going to be amplified through that area. Some considerations when you're doing an assessment of the older adult include that the chest cage itself, again, could be misshapen. So we have the increased AP diameter, we have the kyphosis, we have the scoliosis. We also just have, some stenosis or some arthritis, and all of that can cause a decrease in chest wall expansion, which then causes a decrease in lung expansion. So the patient may or may not be symmetric, but that might be their baseline. And all of this leads to just tiring easily, especially during auscultation. So what I want you to practice is saying to the patient, I want you to take a deep breath in and out through an open mouth every time you feel my stethoscope touch your skin. And then it's up to you as the examiner to move slowly. So this helps you set the pace, and it allows the patient not to feel rushed, because what happens a lot of times if you say to the patient, take some deep breaths, is that they feel obligated to breathe rapidly and deeply rather than just at their own pace. So if you say to the patient, take a deep breath every time you feel my stethoscope touch your skin, then you can set the pace and you can slow things down. Cellular changes occur at the alveolar level, which decreases gas exchange, and this increases the risk of post-op pulmonary complications. So there is no shortcut for doing a good lung exam or pulmonary exam on a patient in the hospital of any age who's post-operatively there, but it is really important in the older adult, especially because their risk of pneumonia status post-surgery is so important. And then also make sure if they qualify for like a hypoventilation protocol that you're keeping a really careful eye on their O2 sat. The lung bases will become less ventilated, and so atelectic crackles, especially in the morning, are going to be more common, and those will clear with some deep breaths. When you're caring for a patient who is acutely ill, it's important to consider always taking a second person in with you to help with position changes. This will make your assessment more accurate, and it will decrease patient fatigue and discomfort. If no one is available, you can log roll the patient from side to side and then kind of assess one side at a time. This might interfere with the bilateral assessment, so you're going to have to kind of remember and take kind of a mental comparison of right to left, because you're going to do all of the right assessment first, then all of the left. The other thing is if the patient has a lot of fluid, this is definitely going to impact your assessment because fluid moves with positioning or gravity. So you'll have some fluid shifting in the pleural spaces as you're moving. So one of the big things that I think is really important as far as critical thinking is what do I do with these adventitious sounds? And so these are vocab words. They're the abnormal findings in your book. They should all be review for you. But the question is, what do you do with them? Don't call the doctor with atelectasis, right? I mean, that would be kind of ridiculous. But if you have an abnormal finding, what you have to ask yourself is, do I expect this to be abnormal? So if I'm taking care of a patient who has COPD or emphysema, I expect there to be adventitious breath sounds. If I'm taking care of a patient who was admitted with pneumonia, I expect there to be adventitious breath sounds. Think about, like, what is the reason that they're there? What's their underlying disease process or history? And is this a normal finding for the patient? However, if I'm taking care of a patient who was admitted with, an appendectomy, and post-op day 2, they now have new adventitious, crackles with a little bit of wheezes on the right side, I'm going to report that because my suspicion is that they're developing a post-op pneumonia. If I have a patient who's in congestive heart failure that normally has fine bibasilar crackles when they're seated, and now they have coarse crackles, to the nipple line, I'm going to report that because their condition is getting worse. But I'm not going to report their daily fine bibasilar crackles because that's an expected finding. So I just really want you to think critically when you're taking test questions, but also when you're out in the floor and practicing clinically. Is this an expected finding based on their admission or their history and presentation? Or is this a change that needs to be evaluated or treated by the physician? Other things to think about would be, tuberculosis, P. carini or P. Jarvis, and then pulmonary embolus. So I just want to talk about this for a second. There's a lot of misconceptions about pulmonary emboli. The patient who has a PE, it's a blood flow issue and not a airflow issue. So a lot of times these patients will have normal breath sounds. So you might hear a little wheeze, you might hear a little crackle, depending on what else is going on within the lung structure. But the hallmark presentation of a pulmonary embolus is tachycardia and hypoxia. About 40% will also have chest pain, but the underlying problem is a inability to perfuse the alveoli to exchange gas, and not an airflow problem. So it is a perfusion issue. Acute respiratory distress syndrome is where you basically have a massive flooding of the respiratory system with fluid from the pleural space, and this occurs usually after some sort of massive systemic insult like sepsis, SIRS, drug overdose, trauma, aspiration of really caustic liquids. So there's been some sort of massive insult to the alveolar membranes. And in this case, what happens is the patient basically is drowning in their own serous fluid. On X-ray, it looks like a complete whiteout. We call it kind of a snowstorm appearance. And the hallmark presentation with this type of patient is that despite high flow oxygenation, so high concentration, high flow oxygenation, their oxygen saturation levels do not improve.